Welcome back to the deep dive. Today we are dispensing with the casual curiosity. We have a very specific high-stakes mission. I'm stepping into the shoes of a tired, caffeine-fueled MD anesthesiology candidate, specifically someone prepping for the Gujarat University final exams. And you, my friend, are going to be the senior MB faculty who holds the keys to the kingdom.
I like the sound of that. It's a role I've played many times in real life. Looking at the stack of books you've got here, Miller, Stolting, the IASP, guidelines, and the syllabus, I take it we are tackling the beast.
The absolute beast. We're doing a comprehensive deep dive into chronic pain, principles, pathophysiology, and management strategies. This is the topic that keeps residents up at night. It's the dreaded 20-mark long answer. It's guaranteed to do in the short notes, and if you don't know it in the viva voce, you are in serious trouble.
That is an accurate assessment, and frankly, for an anesthesiologist, this topic is bread and butter. The examiners, myself included, don't just want a list of drugs. We can look up doses in a formulary. We want to see that you understand the mechanism. We want conceptual clarity. If you can explain why a patient is in pain, the management becomes logical rather than just rote memorization. So, candidate, are you ready for your mock viva?
I'm ready. Let's set the stage. I'm in the exam hall, sweat on my brow. I pick up the card and it says chronic pain. Where do I even begin? I assume I need a rock-solid definition before I do anything else.
Absolutely. You cannot fluff the opening line. You need the safe, examiner-approved definition. For pain, we look to the IASP, the International Association for the Study of Pain. Give it to me.
Okay, deep breath. Pain is an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage.
Spot on. And I noticed you included the phrase, or resembling that associated with. That is a crucial addition in the newer definitions. Why is that specific phrasing so important?
Because it acknowledges that pain can exist without a visible injury. It validates the patient's experience even if we can't see a broken bone, a tumor, or a fresh incision. It covers things like nosoplastic pain, where the tissue is healed, but the patient is still suffering. It basically removes the requirement for us to find a lesion to believe the patient.
Exactly. It validates the subjective experience. Now, the follow-up question you will get immediately to test your basics. How do you differentiate acute pain from chronic pain? And please, do not just tell me time.
Right. So acute pain is a symptom. It's protective and tells you, hey, take your hand off the hot stove. It's usually self-limiting and associated with a neuroendocrine stress response.
Meaning what, clinically? What do you see?
Clinically, I'm looking for tachycardia, hypertension, sweating, dilated pupils, sympathetic hyperactivity, the classic fight or flight stuff.
Correct. And chronic pain.
Chronic pain is fundamentally different. Yes, there is a time component. It persists beyond the normal tissue healing time, usually defined as what, 3 to 6 months?
3 months is the standard cutoff now.
Okay, 3 months. But the key distinction is that it lacks a protective function. It's no longer a symptom. It is considered a disease state in itself. It's pathologic.
Good. And clinically, what about those autonomic signs?
You often don't see them. The heart rate and BP might be perfectly normal because the body is adapted. Instead, you see the vegetative signs: sleep disturbance, depression, loss of libido, changes in appetite. That's the stuff you have to ask about.
Perfect. That is a pass on the intro. You've established that chronic pain is a pathologic state, not just long acute pain. Now, let's move to classification. This is very high yield for your theory paper layout. If you don't classify it correctly, you lose easy marks. How do you break it down?
I'd organize it 2 ways to show I'm thorough. First by pathophysiology, and second by etiology.
Walk me through the pathophysiologic classification. This is the one that really matters for treatment.
Okay, so we have 3 main buckets here. First is nociceptive pain. This is the normal pain machinery working correctly but reacting to ongoing tissue damage.
Right, the wiring is intact.
Yeah. And it's further split into somatic and visceral. Somatic is well localized, sharp or aching like a bone metastasis or a surgical incision. Visceral is poorly localized, cramping or gnawing like pancreatic cancer or bowel obstruction.
Good distinction. Bucket 2.
Neuropathic pain. This is the big one. This is pain caused by a lesion or disease of the somatosensory nervous system itself. The wiring is damaged.
Okay. Peripheral or central?
It can be both. Peripheral, like diabetic neuropathy or postherpetic neuralgia, or central, like post-stroke pain or spinal cord injury pain. And the descriptors here are key for the history taking: burning, shooting, electric shock like lancinating. That's how you spot it.
And the third bucket, this is the one that shows you've read the latest edition of Miller.
Nosoplastic pain. This is the newer category. It describes altered nociception without clear tissue damage or a demonstrable somatosensory lesion.
So what does that mean in plain English?
It means things like fibromyalgia or nonspecific lower back pain fit here. Essentially, the hardware seems fine. No broken bones, no severed nerves, but the software is glitchy. The processing is all wrong.
Glitchy software is a great way to think about it mentally, though in the exam, stick to altered nociceptive processing. And briefly, for etiology.
That's simpler. We usually divide it into cancer pain versus chronic non-cancer pain, or CNCP.
Why is that distinction clinically relevant? Why do we care?
Because the goals of care and the risk tolerance differ completely. In cancer pain, especially in terminal stages, we are aggressive with opioids because the long-term risks like addiction or hormonal changes are less of a priority compared to immediate comfort.
Of course.
But in CNCP, function and long-term safety are paramount. We don't want to create an addiction problem in a patient with a normal life expectancy. It's a totally different ballgame.
Precisely. Now tighten your seatbelt. We are entering the exam core, the pathophysiology. This is where the distinction between a mediocre student and a gold medalist lies. Explain to me how acute pain transitions to chronic pain. What is happening in the nervous system?
Okay. This is the shift from adaptive nociception to maladaptive neuroplasticity. It happens at 3 levels: peripheral, spinal, and supraspinal.
Start at the periphery. I cut my finger, it heals. Why does it still hurt 3 months later?
Well, initially, tissue injury releases an inflammatory soup. That's the classic term. Prostaglandins, bradykinin, substance P, H+ ions, cytokines.
A whole cocktail.
The whole cocktail.
Right.
And these chemicals sensitize the nociceptors. They lower the activation threshold. This is peripheral sensitization. It explains primary hyperalgesia, why the injured spot itself is so tender.
Okay, but that should resolve when the tissue heals, the soup gets cleaned up. What happens if the bombardment continues? Take us to the dorsal horn of the spinal cord. This is the star of the exam.
All right, the dorsal horn, specifically lamina V. This is where the wide dynamic range, or WDR, neurons live. If you keep hitting these C fibers with high-intensity signals, the WDR neurons start to, well, they freak out, they get hyperexcitable. This is the wind-up phenomenon.
Explain wind up to me like I'm a first-year resident.
Okay, imagine a doorbell. Normally, you press it once, it rings once, that's normal pain. But with wind-up, you press it repeatedly, and suddenly the doorbell gets stuck on. It rings louder and longer with every press, even after you stop pressing. The neurons start discharging at a higher frequency for the same stimulus.
Good analogy. Now, scientifically, what receptor is the villain here?
The NMDA receptor. This is crucial. Yeah. Absolutely crucial. Normally, the NMDA receptor is blocked by a magnesium plug. It's just sitting there, inactive.
Right, it's a voltage-gated channel.
Exactly. But with constant depolarization from the afferent nerves releasing glutamate and substance P, that magnesium plug gets kicked out.
And when the plug is gone?
Calcium floods into the cell. This is the match in the powder barrel. The calcium triggers all these intracellular cascades, protein kinase C, nitric oxide synthase. It makes the neuron permanently hyperexcitable. It essentially rewires the connection to be always on. This is central sensitization.
Excellent. Now, you mentioned the neuron rewiring. There's another player in the dorsal horn that we used to ignore, but now we know is vital. It's not a nerve cell.
The glial cells, specifically the microglia.
Yes. Tell me about them. Why are they important?
They aren't just structural glue anymore. When they get activated via things like toll-like receptors, they start pumping out pro-inflammatory cytokines like TNF-alpha and IL-1 beta right there within the spinal cord.
So what's the effect of that?
They basically keep the fire burning.
Yeah.
They maintain that chronic pain state even after the peripheral input has quieted down. They create a sort of neuroinflammatory environment.
Exactly. So in your exam answer, if you draw the central sensitization diagram, which you absolutely should, you must label the WDR neuron, the removal of the magnesium plug from the NMDA receptor, and the activated microglia. That is a complete answer.
Got it. So we have peripheral sensitization making the nerves trigger happy, and central sensitization turning up the volume amplifier in the spinal cord.
And don't forget modulation, or rather the loss of it. In chronic pain, the body's natural braking system fails. We lose the inhibitory control from GABA and glycine interneurons. They just get overwhelmed or even die off.
And the descending pathways.
That's the other part of it. The descending pathways from the brainstem, the periaqueductal gray, the RVM, which usually dampen pain signals, can actually switch to facilitating pain.
So the brakes fail and the accelerator gets stuck.
A perfect storm. Now, let's look at the patient in front of us. We talked about the lack of tachycardia. What are the characteristics of chronic pain that you will see in the clinic?
Well, it's the biopsychosocial mess. Physical signs might include muscle atrophy or stiffness from disuse, because if it hurts, you don't move it. It's a simple feedback loop.
Makes sense.
But the psychosocial impact is huge. Sleep disturbance is almost universal.
Why is sleep so important to mention in an exam answer?
Because it's a vicious cycle. Pain ruins sleep, and sleep deprivation lowers the pain threshold and worsens mood. So they feed each other. Then you have mood disorders. Depression and anxiety are comorbid in a huge percentage of these patients. You can't treat the pain without addressing the mood.
And what about their behavior?
You see pain behaviors, things like grimacing, limping, relying on aids when they might not be strictly necessary. And these are often reinforced by the environment, which is termed operant conditioning.
Right. If a patient grimaces and their spouse immediately takes over the chores, that grimace is reinforced. It's not faking, it's behavioral conditioning. This brings us neatly to the principles of management. If I ask you, what is your goal in treating this patient? And you say, to cure their pain, what happens?
I will fail.
You will fail. So what's the right answer?
The paradigm shift has to be from cure to care and function. The goal isn't a visual analog scale score of 0. That's usually unrealistic. The goal is restoration of function, return to work, being able to sleep, performing activities of daily living, the ADLs.
Precisely. We treat the patient, not the MRI. This is where you must mention the biopsychosocial model.
Right. This is the three-circle Venn diagram that you have to draw. Biological is the tissue damage. Psychological is the catastrophizing, the fear-avoidance beliefs. Social is the work status, litigation, family dynamics. If you only treat the biological circle with drugs, you fail. It's that simple.
Correct. It's a mandatory concept to mention for high marks. Now, assessment. You're in the clinic. How do you assess this complex patient?
Histering is king. PQRST, provocation, quality, region, severity, timing. But for chronic pain, I need more than just a number. The golden rule is pain is whatever the experiencing person says it is. McCaffrey's rule.
Yes, but how do we measure whatever they say it is in a structured way?
We have unidimensional tools like the VAS, the Visual Analog Scale, or the NRS, the Numeric Rating Scale. They're quick. But for chronic pain, multidimensional tools are much better.
Such as?
The McGill Pain Questionnaire is a classic. It gives you qualitative data. Is the pain throbbing or punishing or searing? The West Haven Yale Multidimensional Pain Inventory is another one. And we absolutely must assess mood, so maybe a Beck Depression Inventory or the GAD-7 for anxiety.
Good. You're assessing the whole person. Now, let's talk treatment. Pharmacology. The examiners hate it when you just rattle off drug names. Give me the principles of pharmacotherapy.
We start with the WHO analgesic ladder, originally for cancer, but it's been adapted. Step 1, non-opioids like paracetamol and NSAIDs. Step 2, weak opioids like tramadol or codeine. Step 3, strong opioids like morphine. But, and this is a big but, for chronic non-cancer pain, we are very, very cautious with opioids.
We'll get to that. But what is the most important addition to that ladder for neuropathic pain? The things that aren't even on the original ladder.
The adjuvants, or co-analgesics. These are the drugs that aren't primarily painkillers, but work on the pain pathways we've just been discussing. This is where the real art is.
Give me the classes and mechanisms, conceptual clarity, remember.
Okay. First, anticonvulsants. The big ones are gabapentin and pregabalin. They bind to the alpha-2 delta subunit of voltage-gated calcium channels.
Where, be specific, this is a common Viva question.
On the presynaptic nerve terminal of the primary afferent neuron in the dorsal horn. By binding there, they reduce the influx of calcium when the nerve fires.
And the result?
Less calcium means less release of excitatory neurotransmitters like glutamate and substance P into the synapse. It essentially quiets down the shouting from the peripheral nerve before it can even start the wind-up process.
Good. And for trigeminal neuralgia specifically, the classic textbook answer.
Carbamazepine. That's a sodium channel blocker. First line for that specific condition.
Excellent. Next class of adjuvants.
Antidepressants. Specifically tricyclics, TCAs like amitriptyline, and SNRIs like duloxetine. They inhibit the reuptake of serotonin and norepinephrine.
And why does that help with pain?
Because it increases the concentration of these neurotransmitters in the synaptic cleft, which enhances the descending inhibitory pathways. It essentially fixes the brakes coming down from the brainstem to the spinal cord.
Spot on. That is why we use them. It's a direct analgesic mechanism. It's not just because the patient is depressed, although it can help that too. What about NMDA antagonists?
Ketamine is the classic one. It directly blocks that NMDA receptor we talked about, preventing the wind-up and central sensitization. Methadone is also interesting. It's an opioid, but it also has NMDA antagonist properties, which makes it uniquely useful for difficult neuropathic pain.
Very good. Now, let's address the elephant in the room, opioids. Let's talk opioid stewardship. Why are we so hesitant to put a chronic back pain patient on long-term morphine?
Well, besides the obvious risks of tolerance needing more drug for the same effect and physical dependence, there is the massive risk of addiction. But physiologically, there is another more insidious phenomenon. Opioid-induced hyperalgesia, or OIH.
Explain OIH.
It's completely paradoxical. High doses of opioids can actually make the patient more sensitive to pain over time. The nervous system compensates for the constant inhibition by upregulating pronoceceptive pathways.
So what happens clinically?
The patient says their pain is getting worse, so the
Yeah.
doctor increases the dose, which makes the pain even worse. It's a spiral.
Exactly. And the treatment for OIH is counterintuitive. You have to lower the dose or rotate to a different opioid like methadone. It's not about giving more.
Right. And I should also distinguish physical dependence from addiction in the Viva. Physical dependence is just the body adapting. You get a withdrawal syndrome if you stop abruptly.
Yeah.
That's a normal physiological response. Addiction is a psychological disease. It's the compulsive use despite harm. We shouldn't label a dependent patient as an addict.
A crucial distinction. Now, let's move away from the prescription pad. Non-pharmacological management. This is an exam favorite.
This is where the function goal really comes in. Physical therapy is key. Active participation is everything. It prevents muscle atrophy, and it combats fear-avoidance, the idea that if I move, I hurt, so I won't move. We have to break that cycle by explaining that hurt does not equal harm.
A very important concept. And on the psychological side,
Cognitive behavioral therapy, or CBT. It's not about thinking the pain away. It's about changing maladaptive thoughts like I will never get better or this pain means I'm damaging my back further. It's about developing coping strategies.
what else?
Also, biofeedback. That's a great one to mention.
How does biofeedback work? Why is it effective?
It empowers the patient. You hook them up to sensors that measure, say, muscle tension with an EMG or skin temperature. They can literally see on a screen that their stress is causing physical changes. Then you teach them relaxation techniques and they can watch the numbers go down in real time.
So what's the psychological effect of that?
It shifts them from an external locus of control, expecting the doctor to fix them, to an internal locus of control, realizing they have some agency and can manage their own physiology.
Precisely. That shift in mindset is often the turning point. Now, briefly, interventional pain management. The needles.
Okay. We use them when conservative therapy fails, or maybe to facilitate physical therapy. If someone's in too much pain to even start PT, a block can bridge that gap.
Right. Diagnostic versus therapeutic.
We have diagnostic blocks, like a medial branch block, to see if a specific facet joint is the pain generator. If that works, if it gives them temporary relief, then we know we found the target. Then we can do a therapeutic procedure.
Give me a specific example for back pain.
Radiofrequency ablation, or RFA. If the diagnostic medial branch block works, we go back in with a specialized needle, heat the tip to about 80 degrees Celsius for 90 seconds, and coagulate that little nerve. It stops the transmission.
And that lasts forever.
No, the nerve grows back eventually, but they can get significant relief for 6 to 12 months, sometimes longer. Enough time to engage in meaningful rehab.
And for the really refractory cases, what are the advanced options?
We can mention advanced techniques like spinal cord stimulation or SCS. This is based on Melzack and Wall's gate control theory. You stimulate the large A-beta fibers in the dorsal columns to close the gate on the pain signals coming from the small C fibers.
And what's that used for?
It's used for things like failed back surgery syndrome or complex regional pain syndrome, CRPS. Or you could mention intrathecal drug delivery pumps, especially for refractory cancer pain.
Okay, you're doing well. Now bring it all together. Multidisciplinary pain management.
Or better yet, I should say, interdisciplinary in the exam.
Why? What's the difference?
Multidisciplinary means you have a surgeon, a physio, and a psychologist working in the same building but separately, maybe sending letters to each other. Interdisciplinary means they are in the same room, talking to each other, and creating a single, integrated plan for the patient. It's a much higher level of care.
Correct. Mentioning interdisciplinary shows maturity. So who's on the team?
The anesthesiologist is often the team leader or the interventionalist, but the physiotherapist for functional restoration and the psychologist for CBT and coping strategies are absolutely equal partners. You might also have a social worker or an occupational therapist.
Excellent. Now let's talk about some specific challenges and pitfalls. We mentioned OIH. What is pseudo-addiction?
That's a classic Viva trap. It looks like addiction. The patient is demanding drugs, they're watching the clock, maybe they seem desperate or manipulative, but the underlying cause is simply unrelieved pain.
And how do you fix it?
If you treat the pain effectively, the behavior stops. In true addiction, the aberrant behavior continues even when the pain is well controlled. You have to differentiate.
Very good. And yellow flags. We all know about red flags.
Right, red flags mean serious pathology like cancer or an infection. Yellow flags are the psychosocial risk factors that predict a patient's transition to long-term disability or chronicity.
Give me some examples.
Things like poor job satisfaction, anxiety, pending litigation, or a belief that work is harmful and that any activity will cause damage. If you don't address these yellow flags, your fancy nerve block is not going to work long-term.
Exactly. Now let's prep for the Viva itself. I'm going to throw some Viva traps at you. Common questions examiners use to trip you up.
Okay, hit me.
Trap 1. Doctor, is the intensity of the patient's pain perception related to the size of their injury?
In chronic pain, absolutely no. The relationship is completely nonlinear. A tiny nerve lesion can cause excruciating complex regional pain syndrome due to massive central sensitization. Conversely, you can have a large herniated disc on an MRI that's totally asymptomatic. It's about the processing, not just the input.
Perfect answer. Trap 2. What is the difference between allodynia and hyperalgesia?
Allodynia is pain due to a stimulus that does not normally provoke pain. The classic example is the touch of a bedsheet or a cotton swab on the skin. Hyperalgesia is an exaggerated response to a stimulus that is normally painful, like a simple pinprick feeling like a hot poker.
Good. Don't mix those up. And finally, be ready for the short notes. What are the frequent flyers?
Definitely neuropathic pain mechanisms. CRPS is another big one, complex regional pain syndrome, and I'd need to know the Budapest criteria for that, and probably the role of the NMDA receptor in chronic pain.
Correct. For CRPS, remember it used to be called RSD or reflex sympathetic dystrophy. Knowing the old names shows you've done your reading. And you're right, the Budapest criteria are key. You need to mention symptoms in 3 of 4 categories and signs in 2 of 4 categories.
Right. Now, for the written exam, the diagrams and exam presentation, this is very high yield for scoring well. What should I be drawing?
At a minimum, I need to see a schematic of the dorsal horn for central sensitization. You draw the primary afferent coming in, synapsing on the WDDR neuron, label the neurotransmitters, glutamate, substance P, draw the NMDA receptor popping its magnesium cork, and don't forget to draw the activated microglia releasing cytokines nearby.
Visuals get marks.
They absolutely do. Also, a simple comparison table for acute versus chronic with rows for duration, autonomic signs, component, which is symptom versus disease, and goal, which is cure versus function.
Okay, that's easy enough.
And the biopsychosocial Model 3 overlapping circles labeled bio, psycho, and social with pain experience written in the center where they overlap.
Simple, effective, shows I know the core concepts.
Exactly. Now, summarize this for me. You're at the end of your 20-mark long answer. You need a powerful concluding paragraph that wraps it all up.
Okay. I would conclude by stating that chronic pain is a complex disease of the nervous system, not merely a prolonged symptom of tissue injury. Its pathophysiology involves maladaptive neuroplasticity, specifically peripheral and central sensitization, maintained by both neuronal and glial mechanisms.
Good start.
Therefore, management must evolve beyond simple analgesia to a multimodal, interdisciplinary approach that addresses the biological, psychological, and social dimensions of the patient's experience. The ultimate goal is not just pain relief, but the restoration of function and quality of life.
Bravo. That is a 20-mark answer. You've covered the mechanism, the assessment, the holistic management, and the philosophy of care.
Phew. That feels like a lot, but breaking it down into those sections really does help.
It does. The key with chronic pain is to not get lost in the weeds of specific drug dosages, though you should know the main ones, but to demonstrate that you understand the system failure that chronic pain represents.
Right. It's a software problem, not just a hardware problem.
Exactly. One last question for you, just to make sure you're ready for the curveballs. Why is an anesthesiologist so well suited to run a pain clinic?
I'd say it's because we are experts in regional anesthesia and pharmacology. We know analgesics and local anesthetics better than anyone. We have the procedural skills and anatomical knowledge for nerve blocks. We manage acute postoperative pain daily, so we see that transition firsthand.
Yes.
And critically, we are perioperative physicians who are used to managing complex physiology in real time.
Correct. But remember, the modern pain physician must also be comfortable with the psychosocial aspects. You cannot just be a block jockey.
Block jockey. We'll try not to use that term in the exam.
Not like you're the best. Stick to interventionalist.
So let's just recap the absolute highest yield points for the listener, our fellow exam candidate. 1. Definition, IASP. And you have to mention resembling tissue damage.
Crucial.
2. Classification, nociceptive, neuropathic, nosoplastic. 3. Mechanism. It's all about sensitization. Wind up in the dorsal horn. NMDA receptors losing the magnesium plug. And microglia keeping the fight going.
Don't forget the microglia.
4. Management, biopsychosocial model. The goal is function, not zero pain. 5. Pharmacology. Use the latter, but the focus for neuropathic pain is on adjuvants, the Gabapentinoids, and the TCAs or SNRIs. And watch out for opioid-induced hyperalgesia.
And always mention the interdisciplinary team. Anesthesiologists are perioperative physicians, but in the pain clinic, we are team leaders.
This has been incredibly helpful. I feel like I can actually tackle that question now without panicking.
You'll do fine. Just remember the core principles. Hurt does not equal harm, and care over cure.
Before we go, what's the future look like? What's the provocative thought to leave the listener with?
I'd say it's the move toward personalized pain medicine and genetics. We know that people metabolize drugs differently because of their cytochrome P450 enzymes. In the future, we won't just guess with the WHO ladder. We'll swab a cheek and know exactly which drug at which dose will work for this patient's specific genetic makeup. We're moving from bombing the village with systemic opioids to sniping the target with specific molecular or electrical interventions like dorsal root ganglion stimulation.
From bombing to sniping. That's a great image. Thanks for the deep dive, Professor. And to our listeners, good luck with your exams. Go draw those diagrams.
And remember, understanding the why makes the what much easier to remember.
Catch you on the next deep dive.